Good morning my dear students and future colleagues. This is Dr. Magdi Hassan, Professor of Obstetrics and Gynecology in the Faculty of Medicine of Ain Shams University. It is my pleasure to be with you in a new topic of obstetric curriculum, which is the amniotic fluid and abnormalities of its volume. By the end of the lecture, every one of you is expected to achieve the following. Appreciate the physiological principles and importance of amniotic fluid. List the causes of polyhydramnios as well as oligohydramnios. Describe the symptoms, signs, and investigations for diagnosing polyhydramnios and the same for oligohydramnios. List the complications of polyhydramnios and oligohydramnios. And finally, describe a management plan for both diseases. Before going through the abnormalities of amniotic fluid, we have to talk briefly about the normal criteria of amniotic fluid. Amniotic fluid is nothing but the fluid surrounding the fetus within its sac during pregnancy and labor. Its volume varies greatly with different gestational ages. It is about 30 milliliters at 10 weeks. It increases to 250 ml at nearly 16 weeks. Its maximum volume is reached at 36 to 38 weeks when the volume is 1 to 1.5 liters. The volume decreases to almost 500 milliliters at and after 40 weeks. This post-term decrease is due to the deterioration of placental functions at that age. Amniotic fluid is a neutral fluid having pH of 7 to 7.5. In the early weeks of pregnancy, amniotic fluid is clear and watery, while in later weeks it turned opaque and turbid due to the presence of desquamated fetal hairs, epithelial cells, and vernix, which is the cheesy material covering the fetal skin in late pregnancy. The color and aspect are considered abnormal if it turns yellow, denoting fetal hemolysis, meconium staining in fetal hypoxia, bloody in cases of intrauterine hemorrhage, or purulent in cases of chorioamnionitis. Amniotic fluid is not a stagnant fluid. It is in a state of continuous circulation, that is why it is called to be dynamic, not static one. This means that after being secreted it is reabsorbed, then resecretion of a new amount, and again reabsorption, and so on. This circulation occurs at a rate of almost 500 milliliters per hour. Which means that at full term, when the volume is nearly 1.5 liters, this volume is totally replaced in 2.9 to 3 hours. As we mentioned, amniotic fluid is secreted then reabsorbed. The sources of secretion are both maternal and fetal. The maternal secretion is through placental surfaces transsudation as well as transsudation through amniotic membranes. The fetal participation is through urination and alveolar fluid escaping into the amniotic sac. So amniotic fluid is a share from both the mother and fetus, with the maternal secretion is dominant in early pregnancy when the fetus is still too small to share, while fetal participation is the main in late pregnancy. After secretion, amniotic fluid will be absorbed where the fetus swallows most of it, and the rest is through amniotic membrane surfaces. What are the methods of assessing the volume of amniotic fluid? And how can we decide if it is normal, more than normal, or less? Of course, we have to find an accurate objective way for measurement away from the personal variability. The solution is through ultrasound examination. An obstetric transabdominal ultrasound examination is done as seen in picture to the left, measuring what we call the deepest vertical pocket or DVP of amniotic fluid. The depth of vertical pocket of amniotic fluid in the whole uterus is measured. The deepest one is assessed and used as an indicator to amniotic fluid volume. Normal DVP in near-term pregnancy ranges between 4 to 8 centimeters. The other ultrasonographic parameter used to estimate amniotic fluid volume is amniotic fluid index. The sonographer divides the abdomen into 4 quadrants, with the umbilicus is the reference point. Upper right, upper left, lower right, and lower left. The vertical depth of the largest pocket in each quadrant is measured. The sum of these measurements is the amniotic fluid index expressed in centimeters. At full term, a normal amniotic fluid index ranges between 6 and 20 centimeters. Is amniotic fluid important? If yes, so is it important for pregnancy or delivery? Actually, amniotic fluid is essential for both healthy pregnancy and safe, easy delivery. During pregnancy, amniotic fluid provides the baby with mechanical protection, acting like a shock absorber. Hydrostatic inflation of pulmonary alveoli as the fetus inhales the fluid to train his lungs for expansion. It also provides the medium needed for free fetal movements. It prevents adhesions between the amnion and fetal skin. It keeps the fetal temperature warm and constant. And finally, it provides a medium for fetal excretions. So we can frankly say that the baby enjoys his intrauterine life in presence of adequate amniotic fluid. Amniotic fluid plays a crucial role during labor to make it run smoothly and safely. At the beginning of the process of labor, the amniotic fluid below the presenting part forms the bag of forewater, which in turn helps to dilate the cervix. With the progress of labor and increased strength of uterine muscle contractions, amniotic fluid protects the intrauterine contents, the placenta, cord and the fetus itself, from being compressed by the contracting uterine wall muscles. In late advanced stages of labor, when the amniotic membranes rupture, which we call as rupture of membranes or ROM, the gushing amniotic fluid lubricates and cleans the birth canal because of its aseptic properties. Abnormalities of the amniotic fluid volume are either increased or decreased volumes beyond the normal levels. Abnormally increased volume of amniotic fluid is called polyhydramnios. While abnormal decrease in the volume is called oligohydramnios. Let's start with polyhydramnios, which is defined as the pathological accumulation of excessive amounts of amniotic fluid, more than it should be at that gestational age. The objective indicators of being abnormal or pathological accumulation include ultrasound findings of amniotic fluid index of 25 centimeters or more, deepest vertical pocket of more than 8 centimeters, or a clinical estimation of the total volume to be more than 2,000 milliliters at any gestational age. What are the causes of this undue increase of amniotic fluid volume or the polyhydramnios? Causes can be either in the fetus itself, we call them fetal causes, or in the mother, maternal causes, in the placenta, or more commonly idiopathic. Fetal causes, which account for only 18% of cases, include 1. Multiple pregnancies, when the uterus contains more than one fetus. Of course, the rate of amniotic fluid formation will be more than in single fetus pregnancy. 2. Fetal congenital anomalies, especially those causing increased production or decreased absorption, like open neural tube defects, anencephaly, open spina bifida, upper gastrointestinal obstruction like duodenal or esophageal atresia, omphalocele, the presence of anterior abdominal wall defect. 3. Chromosomal and genetic abnormalities, especially trisomies. 4. Hematological fetal disorders, namely thalassemia. 5. Neuromuscular disorders affecting swallowing. 6. Intrauterine infections like toxoplasmosis and rubella. These anomalies and their effect on amniotic fluid volume will be discussed in more details in the face-to-face session. Maternal causes account for almost 15%. They include diabetic pregnancy, where the fetus is large with large placental surface area, so amniotic fluid production is increased, both fetal and placental. Rhiso immunization is another cause. The hemolysis and sensitization causes fetal hydrops. The fetus is congested, enlarged, and of course secreting excess amniotic fluid. Placental causes are actually very rare, representing only 1% or even less. These include placental chorioangioma as well as circumvallate placenta, where the total placental surface area is increased. The commonest cause of polyhydramnios is by far the idiopathic cases, where no definite cause could be found, neither in the mother nor the fetus. Cases of polyhydramnios are found to have different degrees of severity of complaints and need different plans for management. This means that we have more than one type of polyhydramnios according to the speed of accumulation of amniotic fluid. The acute type, where the excess amniotic fluid volume accumulates rapidly in a short period of time. So usually presents early in pregnancy before 28 weeks, and sometimes earlier weeks may be down to 16 weeks. Of course, the cardiorespiratory pressure manifestations are severe and the outcome is not good. Fortunately, this type is the rare one. In the chronic type of polyhydramnios, the excess amniotic fluid volume accumulation takes place very gradually over a long period of time. So it presents late in pregnancy, usually in the last trimester. This type is the almost 10 times commoner than the acute one. The cardiorespiratory pressure manifestations are mild to moderate and the outcome is usually favorable. As usual, the diagnosis starts by clinical data, both history and physical examination, before proceeding to investigations. A patient with polyhydramnios usually presents complaining of cardiorespiratory pressure manifestations in the form of dyspnea or orthopnea. Also, the patient may express her feeling of having abnormally and rapidly enlarging abdomen. Of course, these symptoms are more evident in the acute than the chronic type. On abdominal examination, the abdominal wall skin is overstretched, so looks glistening, its veins are dilated, with appearance of stria. Leopold's maneuver shows that the fundal level is higher than the gestational age. The fetus is usually malpresented, as the excess volume allows for the free movement of the fetus to change its position and lie. The fetal parts are difficult to feel clearly and fetal heart sounds are faint and very remote. This is how the abdominal wall looks in the patient of polyhydramnios. Stretched glistening skin with excessive stria. The definite diagnostic tool of polyhydramnios is the ultrasound examination. First is to measure the deepest vertical pocket as described before. A value of more than 8 cm is diagnostic. The amniotic fluid index will be found equal to or higher than 25 cm.